normal. Oh.
Okay. Right. So we are live now. Okay. Right. So let's go. So we are in the final stages of maternity. Okay. Today we are starting maternity 3. We're going to look at some high risk medical maternal conditions, and also we look at some how to manage them, and also a little bit of physiology that goes with it. Okay. I have ended this video. If you get a slide, make sure you watch it. It is about the fetal or the maternal, the fetal circulation. Yeah. So it's a short video. So when you get the video, please, the slide, you can click on the link. It's a link. If you click on it, it will. I hope today nobody's screen is blaring. Right. So
No, sir. Today is very clear.
very clear. Let's move on. Thank you. Was
in progress.
Okay. Right. So let's look at some of the high maternal uh, conditions, high risk maternal conditions. The first one we're going to look at is preeclampsia. Okay. You have pregnancy-induced hypertension. You will mostly see this hypertension after 20 weeks. There's a problem with the placenta sometimes. Okay. It releases chemicals and hormone, goes into the bloodstream to cause vasoconstriction. Sometimes travel all the way to the liver, cause issues to the liver. Okay. Yeah. And I mean, it can cause stroke, it can cause seizures and hormones and hypertension, high blood pressure. Okay. Remember, anytime there is high blood pressure, these tiny, tiny, tiny capillaries under intense or severe pressure, they begin to rupture, they burst. Okay. So imagine if the capillaries that are supplying blood to your eyes, they rupture. What will happen? Okay. Yes, you start getting blurred visions. You start getting, if you're not careful, you'll be blind. So these are the things you're going to look at. Okay. Mostly blood pressure greater than or equal to, with the systolic 140/90, plus proteinuria. Proteinuria, or evidence of organ dysfunction. Who can tell me some of the evidence of organ dysfunction? Yes, who can tell me? Let me bring the list of participants. How will you know that this organ it is dysfunctioning?
Decrease
not
urine
working. Come again.
Decrease urine output.
Okay.
Like,
did you say increase or decrease?
Decrease. Yeah. Less than 30 mils per hour.
Okay. Decreased urine output. And what else?
I can see
Yes.
HELP syndrome.
Yes, HELP syndrome is a complication.
Okay.
And
Stroke.
yes, a sign of
Stroke.
stroke. Yes. Stroke, you see that the brain is in trouble. Okay. Yes, any major organ. How will you know that the liver is in trouble?
I can see hepatomegaly, say.
Hepatomegaly, or sometimes right upper quadrant pain. Okay. Yes. And what else? Which organ do you know, and how will you know that that organ is destroying? You're talking to us. Okay, so if I have a blood pressure that's so super high, and I am seeing proteins are supposed to stay in the blood. Okay, I am seeing it in the urine. Protein is a very large molecule. Very, very large molecule. Okay. So on the norms, protein are not supposed to pass through the glomerulus. But the glomerulus, like a colander, is a very small, their holes are very microscopic. It's very, very tiny, small. You can't see with your naked eyes. Okay. The glomerulus. Okay. So for protein to pass through this small hole, and you see it in the urine, yeah, it means this hole has become big. Okay. Or the glomerulonephritis. All these issues, yes, can cause that. So I have a situation that I am losing protein. And remember, the protein inside the blood, their function is to help hold the water. The water in the blood, they will help to hold it. Okay, by holding the water and preventing the water from leaking out into the interstitials. They cause what we call the oncotic pressure. The oncotic pressure, yes. So the oncotic pressure, if you lose protein, you are going to lose a lot of water or plasma or fluid from what the bloodstream. Okay. Pregnant woman has walked to your clinic with high blood pressure, proteinuria, okay, and evidence of organ dysfunction, dizziness, all those stuffs. Okay. Then your eyes begin to open. I'm having what this patient is nearing or knocking on the doors of what preeclampsia. Yes. So in severe forms of this preeclampsia, you see the blood pressure, you see the difference now. Okay. It's shooting up. Platelet is very low. Okay. And the liver function, like I told you, a preeclampsia. The liver begins to struggle. So you see your liver function. You ate banku last night. Okay. Your liver could not metabolize the banku well. You put the liver under stress. I'm not saying anytime you eat banku, your liver is going to be in trouble. No. It's an example I'm making. Okay. So in the morning or with some few days, you realize that what you are getting your AST, the ALT, the alkaline phosphate, okay, and all those enzymes shooting up. That should tell you that what your liver, you are stressing the liver. Okay, you took alcohol. Yes, take alcohol for 1 week. Go and check your liver enzyme. You see that it's up. Okay, yes. So the liver cannot survive this preeclampsia cascade going on in the system. And when that happens, it will generate another complication for us. Okay. Another thing too is when you don't do anything about this, or when you don't control it well, it will lead you towards eclampsia. So all these signs and symptoms plus seizure is what we call what? Eclampsia. Take all these signs and symptoms minus seizure. You have preeclampsia. That's the difference. Okay. That is the difference, guys. Okay. All these signs and symptoms plus seizures. Seizure is the denominator here. Okay. So your precautions, remember. Okay. Now let's look at the management. They said give magnesium, mag sulfate. Okay. Magnesium will block all these seizure spikes or seizure thresholds. Okay. It will increase it. It will stop all the nonsense. I remember magnesium is coming straight in the body to stop all these things. It will work on the muscles to reduce the muscle activity, because seizure is about muscle activity. Okay. If you are not careful, or if you become happy that let me give magnesium, mag sulfate, you are happy that you are giving mag sulfate. You will keep sinking or suppressing the muscles. Okay, when you suppress the muscles, remember, you have made the muscles flaccid or weak. How about the tendons? Okay, that connects the muscles and the what? Remember, this is my bone. In between the muscles are connected to the bones by a connective tissue. We call this one the tendon. Who knows the biggest tendon in the body? Who knows?
The Achilles tendons.
Achilles tendon. Good. Right. So I have given magnesium. My aim is to prevent seizure, okay, or stop seizure in these muscles. Because these three guys work together, this is my tendon in between. Okay. And this is my bone. Because they work together, you see the effect of the magnesium on the tendons. So if magnesium is suppressing the muscles, it will also suppress the tendons. Please, do we understand?
Yes,
So
sir.
let's go into the body. Where are muscles? Okay. Magnesium is going to what? Calm them down. Hey, Jack, slow down. Okay. Magnesium stops all nonsense. An asthmatic that is getting status asthmatic cause, epileptic status. I mean, somebody is getting allergic reactions, all this. We've gone to massive blood transfusion, massive fluid resuscitations, all these minor reactions that occur to one you can't see with your naked eyes. You give magnesium to stop, calm the system down. Calm the system down. Okay, magnesium is one of the magic medications. Okay, one of the magic medications is called what? Magnesium. Yes. So you realize that what you can't give magnesium to work on muscles and the tendon will be free. No. I'm showing you one trick. The one who is smart will know, because in examination or when you are doing any presentation, when you talk about muscle effect, remember the tendons are connected to the muscles. Okay. Yes. So you see what the reduction in what deep tendon reflex or reflexes. Okay. They will go to the negatives. So maybe +1.
It's like downstairs.
Or 0, whatever. Do we have 0? No, we don't have 0. So make 2 the center. So the +3 and the +4. So those who are going to write anklets, please mute yourself when you join. Those who are going to write anklets will not tell you the tendon has reduced. Anklets will bring you plus. So on assessment, DTR, deep tendon reflexes. If I mute you, then you unmute yourself. The deep tendon reflexes. So they will give you +3, +4. Okay. These are hyperreflexia. Okay. Hyperreflexes. Something is stimulating the tendons. So a patient who is having +3, +4, is it going to become, are the muscles going to become, because the tendons are already shaking. Understand? So I'll give max sulfate to reduce the strength down. Okay. Yes. The antidote is what? Calcium gluconate. Calcium gluconate. Yes. So you give calcium gluconate to what? To stabilize what? The membranes, the cardiac membranes, especially in situations where potassium too is in trouble. Okay. Calcium gluconate is very important to stabilize the membranes. Yes. So when you are getting arrhythmias, give calcium gluconate. Yes. To then you know your normal seizure precautions, very, very important. Then you deliver the baby. When your patient gets eclampsia, okay, also think about the baby's delivery, very important. Okay, so this is what one of the complications. We have so many hypertensive, we have somebody who is pregnant, who didn't have any hypertension, okay, and the pregnancy has brought about hypertension. So we have in total, we call the pregnancy-induced hypertensions. Okay. So pregnancy-induced hypertensions, what are the classifications? We have somebody, I always explain it this way. You were not a hypertensive patient, then you got pregnant. Now you have hypertension. Okay. So yes, your hypertension is caused by, or the pregnancy is induced. Okay. Yes. So that one is there. Then we have somebody who was hypertensive before HPT or HTN, before becoming pregnant. And now the hypertension is increasing, is going to the 60s. Okay, 160s systolics after the pregnancy. So we have what? Hypertension superimposed. You were on the denominator, you were having a hypertension, and now the pregnancy has also brought another hypertension. So we call it hypertension. This new hypertension, it is superimposed, above imposed, superimposed on this old pregnancy, hypertension. That is also there. Okay. Then we have the preeclampsias. Preeclampsia. All these ones, you are not going to find proteins. Okay. You are not going to find all these proteinuria and all those stuffs in the blood. Right. Then we have, you are still pregnant. Okay. There are issues with placenta, hormonal dysregulations, placenta attachment. Okay. All these issues can cause hormonal effect. Okay. And you see your proteins, you see, the liver in trouble and all those stuffs, okay, coming together. It's like a cascade, a syndrome, okay, a group of signs and symptoms, occurring at the same time. Okay, so you experience what we call the preeclampsia. If you don't do anything about this preeclampsia, you get eclampsia. Okay. With the preeclampsia, you'll be seeing traces, protein trace. Then we go to +1. Then go to +2. Okay. Yes. +2 going on. Keep eyes on. Okay. Or +1. So these are the things you should know. Okay. And let's look at HELP syndrome. The HELP syndrome. Yes. For all these problems going on, you are not doing anything about it, you can get a condition we call the HELP syndrome. The HELP syndrome is a combination of complications that occurs at the same time, the two L's. So this is what hemolysis of the red blood cells. Yes, Jenny, keep your question. When I finish, then you ask your answer. Okay. Don't forget to write it down. So hemolysis of the red blood cells. Red blood cells will hemolyze. They will break down. Okay. They will break down. Then the EL, that is lumbar. Okay. The EL is what? Elevated liver enzymes, like you are seeing here. Then this one is what? The low platelets. Low platelet. When platelet becomes low, the quantity of platelets in the bloodstream also goes low. So you are pushing yourself into what condition? Disseminated intravascular coagulopathies. This is the low platelets. Elevated liver enzymes. Yes, liver is under stress. So what do? You will see your AST, the ALT, the alkaline phosphate, all those liver issues also got shooting up. Then the hemolysis, the red blood cells, they break down, they break down, they break down. We need red blood cells for what? Inside the red blood cells are hemoglobin. Hemoglobin. Yes. This hemoglobin are supposed to carry oxygen to what? To the body, our other body parts. Yes. So if this red blood cell breaks down, can this hemoglobin do that job? No. Okay. Yes. So these are the things you should know. Okay. So there is a risk of DIC for the low platelets. So you deliver when you see HELP syndrome, deliver the baby, then your mark surface to prevent any future reactions, seizures, and all those stuffs, please. Okay. Now, let's go down. The third condition we are looking at is what? Gestational diabetes. Gestational diabetes. Okay. Yes. So, we have the GTTs, I mean, the glucose testing and all those. We have so many ways. The other time we did it. Who remembers it? Who can say something about it? A pregnant woman is coming for antenatal. At a point with the journey, we will check for glucose. Okay. Sometimes when they go, they make them fast for some hours. So we check. Then later we can also give you glucose to drink. Take the sample again, go and check. So these are all what? Who remembers? Yes, where are the midwives? Among us, who can say something about it? So the glucose tolerance test, the GTT, mostly between 24 to 28 weeks. Okay, the second trimester at the phase of what? Prematurity, the glucose. Why is glucose a concern? Okay, I have told you that inside the mother's blood vessels, they are connected to the baby. Okay. Just that when it gets to the level of the placenta, instead of you to see these blood vessels, you will see these blood vessels inside a certain cord. We call them what? The umbilical cord. That's it. We wrap nicely. Okay, so this is the uterus, this is the placenta. So remember, I have high sugar here coming straight from the mother. It is going to the baby. The baby cells will pick the glucose, the sugar, okay, metabolize it, form glucose, fat, and all those ones. So you see the baby becoming big, macrosomia, okay, yes. And they also have issues with what? The type 1 diabetes. So sometimes hypoglycemia and all those stuffs comes in. Okay. Yes. You encourage with gestational diabetes, encourage breastfeeding. It improves what? Glucose control. Especially when the mother gives birth. Okay. So you encourage what? Breastfeeding. Then you maintain fasting blood glucose level. This is in milligrams per deciliter. Okay. In Africa, we use what? The millimoles per deciliter. Okay, millimoles per deciliter. Okay, so take this number divided by 18. That's where you get your answer. That's it. You don't have to chew it. Divide by 18, you have your answer. Okay. if you want to convert it. But countries like US, they do the milligrams per deciliter. Okay. So your fasting blood sugars is very important. Now let's look at placenta previa. I have my uterus here. And I have my hole, the cervix, the orifice. Yeah. I need this baby to pass here. The placenta is supposed to be here. And this is the baby, the umbilical cord connecting them. Okay. I can get situations or circumstances where the placenta in positioning itself or embedding itself into the walls of the uterus. Instead of it to be at the top here, you see it what forming or embedding itself here. Sometimes they even close this hole totally or partially. They leave some hole there. Yes. The placenta is inside what? It is covering. Remember, if you want to remember this, always the baby should be what? Below the placenta. So you measure when you do your ultrasound measure, baby should be below the placenta. And the placenta should be above. Okay. If I get a situation where I have the baby at the top and placenta here, it means the placenta has taken the lead. The lead. Okay. In Ghana, they will say, "Wedi kind." Okay. They have taken the lead. The placenta has taken the lead. So placenta previa. Okay. It has taken the lead. Sometimes it can take the lead and cover this orifice. But one thing I want you to know is that this placenta taking the lead is not tearing any muscle here. It is just a problem with the positioning when it was what? Embedding itself into the walls of the uterus. That's a more positioning. Okay, a problem with the positions. Yes. So what now happens? You will see bleeding. You see bleeding. The woman will be bleeding, but they don't feel pains.